Freedom HealthWorks is the direct primary care accelerator. We help doctors across the country start fresh in direct primary care. With Freedom HealthWorks, you work with a team, not a checklist. Visit freedomhealthworks.com and together we can achieve true freedom in direct care.
From Freedom HealthWorks, it's Healthcare Americana, a show about innovators, idealists, and pioneers in healthcare. These are their stories. I'm Christopher Habig, and on today's show, how Shawn and Janet Needham took their local pharmacy and turned it into one of the area's first all-cash pharmacies. Shawn Needham and his wife, Janet, are a dynamic duo, working together since the late 90s in their business, Moses Lake Professional Pharmacy. On first glance, this is a success story for an independent compounding pharmacy, but when taking a deeper look, there's something unique happening. Moses Lake Professional Pharmacy hasn't accepted health insurance since 2002. Shawn, what makes your pharmacy and your approach so different?
Well, I think you just said it actually, not accepting health insurance. I don't know the actual numbers, but I'm sure it's less than, you know, 5% of pharmacies that don't accept health insurance. And we get it all the time when, we talk to other pharmacists or other pharmacies and they're like, well, what do you mean you don't accept insurance? How do you get paid? It's like, well, cash, check, credit card.
Open up
Which
your
is
wallet and see what's in there.
right. It's a novel concept in healthcare anymore. As you know, from being in the industry, um, that, people pay for their services. So, you know, um, that's why it is so rare and so unique. And if you see what is going on now in healthcare, there's a lot of doctors and clinics and the like that are now going towards a cash model because they know the traditional health insurance model is just not working. It's
Mhm.
probably not the best thing for patients, and it's definitely makes things way more expensive.
Absolutely. So tell us a little bit more about what a compounding pharmacy is or what it does.
So we are a compounding pharmacy, and essentially what that is we customize our medications. So we make up medications from scratch from the raw chemicals. I like to say that as a compounding pharmacist, we are the uh, what we do what traditional pharmacists used to do, 70, 80 plus years ago is when the drug manufacturers largely took over the pharmacy industry. And before that, and thousands of years ago, what a pharmacist did was, more of an apothecary. They would take individual ingredients on a prescription from a doctor, and they would mix it up into a finalized dosage form for an individual patient. And that's just what we're doing. I believe that that compounding is the past, present, and future of pharmacy. And it's just so nice to do customized, individual, personalized care with patients. It's super rewarding.
Now, that personalized, customized aspect of working with patients, why take this approach? When most people think about pharmacies, they think about whatever chains down the road. Why this approach, and why have you been so successful?
Well, I think the future of many things is personal, and I think when years ago in healthcare, I think healthcare used to be personal. Um, But one thing that we've done now, I think partly because of all the big insurance stuff that's taken over healthcare, is that there's individual physicians, individual pharmacists, they don't get to take care of a patient. They're told how to do it by an insurance company. And I think you may be familiar with this with what's called the standard of care. Well, standard of care, um, you know, how to treat, thousands of different patients doesn't mean that that's how one individual patient needs to be taken care of. And my wife likes to say that, standard of care doesn't mean quality of care. So that's why we stepped outside of that realm and we like to treat an individual patient.
hmm Now, you've been doing this for a while. So take us back to when you first got started. Like I mentioned before, you started this pharmacy with your wife back in the late 90s. How did this come about? Where did this idea come from?
Yeah, well, my wife was working for a local independent pharmacy, and I was working at at a hospital pharmacy in the inpatient realm. So I was working with a lot of individual physicians and doctors, and got to build a relationship with them. And my wife was, had got to build a relationship with many patients. There came an opportunity to come around that we had an opportunity to build our own pharmacy or open our own pharmacy, and we decided to take advantage of it. I talked to some of my colleagues, uh, and I said, "Hey, is there still a way that you can make a living at an independent pharmacy?" And one of the things that they said, is anybody in your area compounding?" I'm like, I didn't even know much about it, honestly. I took a class in pharmacy school, and it's an interesting story because in pharmacy school, when I took that class, they said, "Oh yeah, we're thinking about canceling this class. Nobody compounds anymore." And and now the interesting story is that I'm the an assistant professor at the University of Washington, and I teach the advanced compounding course now. So it's kind of come full circle for me.
Uh,
Um, and it is an elective, and I think it should be an elective because not everybody is going to have the opportunity to do what we do. But I think there's a big, big future in it. So, we opened up in 1998, and we were a full service pharmacy. We billed all the insurance, we filled regular prescriptions, and we did a little bit of compounding. That took some time to grow. And we also had medical equipment. We sold medical equipment. We were a full service pharmacy. And then in 1999, I was doing a quick audit on a prescription. At the time, there was a pharmacy benefit manager, also known as PBMs. They've been in the news a lot lately. There was
mhm.
one called PCS, and PCS stands for Prescription Card Services. And um, I did a reimbursement. I did a little quick audit to see what we were getting paid, and we were getting paid like 50 cents over our cost of the drug. That didn't include the vial, that didn't include the label, that didn't include my time, the light bill, none of that. 50 cents over my cost. Obviously, I was losing money. Now, in healthcare, what some people would say, and this is what many of my colleagues tried to no avail, is that, well, you got to make it up on volume. The only way you can do it is make it up on volume. But you know what? I mean, Econ 101 is, if you lose money on a transaction, the more of those transactions you do, the more money you lose.
Right. There has to be some type of margin, a healthy margin for your business to be
Right.
able to survive, and then you
Right.
add volume. That's the
Right.
point of it, right?
Correct. Correct. So I realized right away that no matter how much volume of that prescription I did, there was no way I was going to make any money. So that was the first insurance company that I turned down, which it really wasn't an insurance company; it was a PBM. But in pharmacy, we link PBMs really with insurance companies because they're a middleman, they're a third
Mhm.
party, they're involved between us and the patient. So that's what I call them. So that was the first one we turned down, and then we could see right away that the other insurances weren't much better. So we were kind of just slowly whittling away until 2002. We actually said no to our state Medicaid program.
Mhm.
And we were one of seven pharmacies in the state that said no. Yeah, one of seven pharmacies in the state out of 1,400 that said no to this program because they were decreasing the reimbursement by 25%. So we finally said no more. We're not going to take that. So that's when we became cash only in 2002 is when that was the last insurance our pharmacy billed. Now here's the interesting thing is we 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 billed insurance most of that year, and we were very busy. It was the busiest gross sales year we ever had, even to this date, and we lost money.
Wow.
Yeah. So just because this is what people forget in healthcare is that just because you're busy or just because you have a lot of staff or just because you're doing a lot of work doesn't mean you're making money.
Right, right.
So, yeah.
Let me ask you this. So, approaching this from the other side, somebody listening might say, well, okay, that PBM was actually doing its job and saving me money. Maybe the pharmacy doesn't make any money, but what's your response when you hear something like that of, oh, isn't insurance and these PBMs supposed to be saving my company money? Aren't they just doing their job at this point?
Well, I got to tell you that I don't know the details about the PBMs anymore, and I can't say I knew the details in 2002. But I will tell you this is that the PBMs have nothing to do with taking care of the patient. They have nothing to do with um, saving anybody money besides themselves. They are in the business to make a profit. And I'm a capitalist. Don't get me wrong. I'm a capitalist. I've got no problem with people making money. But when they make huge dollars on the back of healthcare providers, i.e., pharmacists, that's where I have a problem. Now, I mean, it must work for most of them because you see a lot of pharmacists, complain about reimbursement from PBMs and how PBMs take advantage of them in so many ways. But most pharmacists don't have the guts to say no and say, you know what, I'm done with them. So I don't blame the PBMs for doing it because pharmacists and healthcare providers, if you look at just the whole insurance model, um, they do this and they take profits out of the back of healthcare providers because healthcare providers have let them do it. Until healthcare providers tell them no and say, "I've had enough," it's never gonna stop. Perfect example, in 2002, when we said no to our state Medicaid, we were, I don't know what those numbers are, statistically speaking, but 7 out of 1,400 said no in the state. Well, guess what happened 2 years later when the budget cycle came up again? They decreased reimbursement again. And those same pharmacists that said they were going to say no were still whining and crying and saying, "Yeah, you decrease this reimbursement again. I'm not going to take care of this set of patients. I'm going to say no." Guess what? They didn't, and I don't feel sorry for them anymore. I used to feel sorry for them, um, but until they stand up for themselves and say no, it's going to continue to happen. And in the words of a great doctor who started the Surgery Center of Oklahoma, Keith Smith. He said that when he was under some of those insurance plans like Medicare and Medicaid, he felt like an accessory to the crime. And you know what? I'm starting to use that term more because
Right.
I realized that when I was under those programs, I was an accessory to the crime. And I think that healthcare providers that keep playing in that model is an accessory to the crime.
That's a very powerful statement indeed. So, want to take a step back there. So when you're going through college, you basically are going into an area of focus that the university was saying, "Hey, we're not going to sure we're going to offer this class anymore." And now you're teaching this compounding class. And I think you answered this next question already. So as you've been building your business, you've been educating the next tier of pharmacists coming along. Do you ever see yourself going back to that old third party model now that you have a taste of these past 18 or so years since 2002?
Never, never will I go through do that model again. I will never bill a third party insurance ever again. It puts a third party between the doctor, the patient relationship, the doctor, patient, pharmacist relationship, and it is not equal good care. You go after, when you look at what that does, you actually end up going after billing codes and going after diagnosis codes so you can bill the insurance and check it off the box. Um,
Hmm.
instead of really taking care of what the patient's needs are, you're going after something that the insurance company asks you to do.
Right.
So no, I can never look at that again. My wife and I are thriving now, and let me just tell you what I believe thriving is financially we do great. Um, Thriving to me is that we are liberated. we are liberated from those PBMs, from those third parties. We get to take care of the patient the way we want to take care of the patient, along with a prescriber, doctor, and
Mhm.
it's wonderful. It is very, very professional and rewarding. Um, I see value in that because patients come to us because they like our service, they like our knowledge, and at a decent price. And when you have a third party involved, most of the time the people go to a certain, when they have an insurance, when they go to a certain doctor, they go to a certain pharmacist, they go to a certain clinic, they're going there because the insurance told them that's who their preferred provider is. And that is not very professional rewarding. I can't imagine being in that situation where, great, the only reason you're coming to me is because your insurance company told you to. That's not very rewarding to me.
No, you mentioned a couple of big things I always like to highlight there that when you're talking about insurance codes, we always joke within Freedom Health Works, it's kind of a sad joke, really more gallows humor, that there is no ICD code, CPT code for curing somebody, for healing a patient. There's only codes and billing. You only get paid by keeping this person ill and keeping them in the system. You touched upon briefly upon price. We talked about PBMs and those programs a few minutes ago, but I'm curious to know when you stopped taking insurance, stopped taking health insurance from third party payers, what kind of pressure, what kind of movement did that have on the prices that you were able to charge?
Yeah, well, so let me just, I got to go into that a little bit in detail. So realize that one of the things is that there was still, when we stopped billing insurance, in the late 90s, early 2000s, there was still a large cash prescription market, and that market was the Medicare patients, because Medicare Part D did not come into play until I think 2006, 2007 ish. So by the time Medicare Part D came into play, which um, we weren't in the insurance market anymore then, um, we were already out completely of the insurance market. We were already billing cash. So realize that in the 90s and before that, um, Medicare did not cover prescriptions. Okay. So the cost of prescriptions was a lot less because drug companies and pharmacies had to be more competitive with their pricing because the average person was not going to pay $500 a month for a prescription out of pocket.
Hmm.
So, back then the price was a lot less. And the reason why is because there was no Medicare covering prescriptions yet. So, speaking of pricing then, so our pricing didn't change a lot right then because there was still a large cash market. So, pharmacies still had to be competitive. Now, what I will say is that, our what we do in our pharmacy, we don't do a lot of regular type prescriptions. So you're not comparing apples to oranges necessarily, because we do a lot of custom stuff, the compounding stuff. So it is a little bit different that you can't just compare an apple to an orange as you could at a chain store that's dispensing, an XYZ prescription. That being said, our prices are still a lot less than what your average pharmacy would be charging for a regular prescription. So when Medicare Part D came into play in the mid 2000s, the next year the price of prescription drugs went up 19%. Not a surprise. I talk about this in my book. My book is called Sickened: How the Government Ruined Healthcare and How to Fix It. And it talks about some of these pricing and what has driven some of the high costs of healthcare. Um, so, whereas our average price of a prescription has really stayed pretty flat. In fact, there's some things that have went down. So nowadays, the average price of a prescription for a month's supply at a regular pharmacy in the United States is over $500 for a month's supply of one prescription, whereas our average price of a prescription for a 3 month supply is like $98. So you're talking
Wow.
yeah, you're talking
Wow.
1/15 the price. Now, why is that? Well, because our individual customers, our individual patients, They're the ones paying the bill, not a third party. So we have to be more price competitive, because it's not a third party paying the bill. So it's pretty simple econ, really.
Yeah, and that is not a insignificant amount of savings right there. You get 3 times longer for 20% of the price. I mean, that's a no-brainer win for any patient out there that needs some medication to help them treat or eventually get better. Um, that is it's
And
just astounding, and I'm kind of sitting here and my jaw I think hit the floor when you said that. So I appreciate you sharing that with
yeah,
us.
another thing I just want to touch on is most of what we do is customizing prescriptions. So somebody could argue that, you can't compare this to a regular prescription, but I will tell you this, I do know, and I'm working with a guy back in the Midwest that's opening up a cash only pharmacy, and he is going to focus on regular prescriptions, so not necessarily compounding. I don't know if he's doing any compounding actually. And basically what he's going to do is um, he's going to sell mostly generic medication at a very, very reduced price. So you're talking 10 to 15 bucks for a 3 month supply. Um, Whereas, when you go to you go to your regular pharmacy that bills insurance and you tell them, well, I want to get this medication. And the first thing they say is, well, it's $105. Oh, you don't have insurance? Okay. Well, if you don't have insurance, then all of a sudden the price is $15, or some crazy thing. So you can just see how, healthcare providers have really become accessories to the crime when they bill these exorbitant amounts to these insurance companies, and then patients without insurance really get it stuck to them, and patients with insurance get it stuck to them, because really in reality for most of those common everyday non big claim type stuff. I'm trying to think of the words. Catastrophic.
Mhm.
Health insurance used to be catastrophic stuff. Um, for a lot of the doctor's visits, for your eye stuff, your pharmacy stuff, you are better off, in my opinion, many times paying cash for it instead of running it through your insurance, because they automatically charge more because you run it through your insurance.
Mhm. Mhm. Absolutely. Um, Now, Shawn, you're very active, very vocal about your principles with your business and with your personal principles. And you mentioned your book, but you also host a radio show. So, what's your experience been? How do people respond to your message and what you have to say on a weekly basis, and then through your book in written form?
Yeah. So our radio show is Health Solutions with Shawn and Janet Needham. And we talk about everything healthcare. So we don't just talk about some of these issues with pricing and the cost of healthcare. We 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 decided to focus our you mentioned earlier that there is no diagnosis code for healing.
Hmm.
And when you look at our sick care model in healthcare, I mean, that's all we do is we chase these codes. And I know this sounds horrible to some people, including in the healthcare industry, when I say this, but let's face it. Let's take diabetes for instance. Do you think that your average doctor, your average clinic, that's um, really being an accessory to the crime with somebody that has type 2 diabetes, let's say, and they're on Medicare, do you really think they want that person to not have diabetes anymore? They prescribe another medication. They know what kind of how often the insurance company will let them come in to do a certain procedure, whether it be monthly, whether it be every 6 months, and they know those, they chase those diagnosis codes. When in reality, let's just say it. And I talk about this on my very first episode of Health Solutions. Diabetes is a diet and lifestyle related issue. I get it. I'm a pharmacist, so people, don't have to correct me that type 1 diabetes is different. I get that. But I also realize, and if you watch our first episode, that type 1 diabetes still has to be controlled with diet. I get it. You need insulin as a type 1 diabetic. I understand that. But you don't need as much insulin as some of the healthcare system tells you, if you watch your diet and you watch your exercise and you monitor that well, you don't need as much insulin, and you don't need that fancy designer insulin that's $600 a month or whatever the prescription is, or you know, you can get insulin over the counter. So, but that's how the free market works. Um, you have to do that yourself. So with our radio show, I want to educate and empower patients that they are in control. Um, and type 2 diabetes, um, is a great example how, if a type 2 diabetic, the average type 2 diabetic in America, if they watched what they ate and they exercised and they were given the education to do those things, um, they wouldn't need medication. They wouldn't have to go to the doctor regularly. But there again, then all of a sudden, there's not a diagnosis code that a doctor or a clinic or a pharmacy can chase. So, you
Right.
know, at our pharmacy and with our radio show, we want to educate and empower patients that they are in control of their own health care. And the best health insurance we have is not something that we can buy. It is how we take care of our bodies. It's not some premium, it's not some insurance that you can buy. It's how we take care of ourselves. That's the best health insurance we have.
Hmm. Hmm. It sounds like an absolute fascinating show. So you've won another listener here, and I know you mentioned it's available on iTunes. And so the name of that again was Health Solutions with Shawn and Janet Needham, available on iTunes there. So let's talk a little bit more about the book that you wrote. Um, I always enjoy talking to authors because they're the people who've taken the time to put their ideas and put their thoughts down on pages and help spread the word that way, which I'm pretty sure people still read books at this day and age and not just listening to podcasts all the time. So tell us a little bit about your book and really what inspired you to write it and what's your goal with putting that together?
Well, let me tell you, thank you for that. And yes, being an author is something I didn't really ever plan on doing, but the book was, I like to say 25 years in the thinking and 5 years in the making. It is, even though it's a short book, it's only 114 pages, so it's a quick read. Download on Amazon. It's only available on Kindle, Amazon right now. We're working at a hard copy and hope to get it released later this year. Also have it in audio format. And yeah, people still do read books. In fact, the book for a while was a number one seller on Amazon. The Saturday after we released the book, there was 1,371 downloads on that Saturday.
Oh, wow.
Yeah, so I was kind of nervous about it. I didn't know how it was going to go over. I thought I might have some, a lot of negativity over it, but I think people were looking for something like this. Um, because I'm surprised the people that have come out of the woodwork to support the project. And I just over the last 25 years, just some of the things we've been talking about over the last few minutes, it's been frustrating for me, to to navigate as a healthcare provider that market, and I see my patients that would suffer in this health insurance driven industry, in healthcare, and my wife and I would just take things for granted. We know how to navigate the system because we've been in the system, you know. So we know how to navigate the system. Unfortunately, most patients didn't. So they didn't
Hmm.
know that you could, pick a different doctor or pick a different hospital, or when a doctor says that you need this, that, or the other medication, that you can say, well, wait a minute, why can't I get this medication that's less expensive or a different generic, or something like that? We just took those things for granted. So we want to educate patients that, yeah, they are the driver of that. They're in charge. They're the consumer. So educate and empower is really what I wanted to do, with that book and our radio show, and it's just been wonderfully received.
Great. I'm glad to hear that. And I know just looking at your book a little bit, you do offer up solutions to fixing healthcare. And this leads us into our next segment. So, a new segment to this season of Healthcare Americana is what we're calling our Crystal Ball segment, where we ask our guests what's next in healthcare from their perspective. So, Shawn, obviously you're in the hot
Mhm.
seat here, gazing in your crystal ball. Where does your company, and where's the industry go from here?
Well, I think one thing is empowered patients, just like I just said, and I can't reiterate that enough. Patients need to be empowered so they can be in charge. Now, ultimately, when that happens, they are going to have to make decisions for themselves that traditionally in healthcare they might not have done. So, first of all, when patients are empowered, they should be in charge of their own health. And first of all, when they're in charge of their own health, they're not going to need a lot of healthcare per se. Now, we could define, we talked about it earlier, but healthcare versus sick care. But if they take care of themselves, they're not going to have a lot of healthcare necessarily. At least not a lot of sick care. I mean, you look at the disease states in this country that are rampant: um, high cholesterol, high blood pressure, diabetes. Um, there is, and those are all lifestyle changing diseases that you can change by changing your lifestyle. Now,
Hmm.
in our healthcare system, because we chase diagnosis codes, we prescribe another medication for that. When in reality, if we take the time as healthcare providers to educate and empower our patients, they wouldn't need those medications. So largely, I mean, there are exceptions to that.
Sure.
So I think that's the first thing is to educate patients about that, and then educate patients that there are doctors, hospitals, clinics out there that aren't accessories to the crime. So when I say that, I mean there are doctors and clinics out there that um, are cash only.
Hmm.
There's a lot more of those, and I think it's the future. Um, you know, I've been surprised, really surprised how many, DPC or direct primary care physicians there are across the nation. I, you would know these numbers better than I would, but I don't think there's an area because I live in small town, rural Eastern Washington, and we can find them all around us. So
Hmm.
I'm thinking if that's the case here, where are they not? You know, and I see them on Facebook all the time in all kinds of communities. So I think
Hmm.
that's a big future is those primary care doctors, and then there's specialists, because you're always going to get the argument. Well, what about if somebody needs a surgery? Well, thank you, Dr. Keith Smith, for starting the Surgery Center of Oklahoma, because I mean he has revolutionized the industry. He's everywhere we go. We were at an event last night and in Tacoma, and people had heard of the Oklahoma Surgery Center, the Surgery Center of Oklahoma. I mean, it's wonderful. He has revolutionized the industry, and he's really went out on a limb to do that, and it could have cost him a lot. And I so appreciate doctors like him that are entrepreneurs and just free thinking and want to ultimately, do what's best for their patient. And one of those things is that what some doctors don't realize is that when you take the Hippocratic oath, do no harm, that includes financial. So when one hospital charges 40,000 and the Surgery Center of Oklahoma charges 4,000, and you send your patient to the hospital that charges 40,000, you know, you got to think about that. I'll
Hmm.
let our viewers and listeners think about, the what that means. Um, so and then so we need to change patients' mindsets that they can drive that. They can use cash physicians and healthcare providers, and they're consumers. So, price shop. You know, i- i- most medical procedures are price shoppable. I mean, do it. Price shop them. Price shop pharmacies. Price shop doctors. Price shop surgeries. And I really do promote that. So, and where it gets a little bit tougher is when you go down. In my book, I talk about a 6-step solution, and when you go down that um, that cascade, the last 2 steps are a little more difficult because they involve state and federal government. The sixth one involves the state government. The seventh one involves the federal government. And basically, ultimately, mean, ultimately, we have to get the government out of healthcare. The title of my book says it. I believe the government's what ruined it. I believe strongly in that. And if you read my book, you will look at the specific steps the government took that really, really went down the road to ruining our healthcare system. So they've got to get out.
Sure.
As much as there's been talk since whenever about the price of healthcare and how the government's going to fix it, they're not going to fix it. And they can't fix it. The government can't fix those problems. They're the ones that caused it. They're not going to fix it. Ultimately, we have to get them out. That's a big step.
Sure.
Repealing Medicare. The government's created a big voting block with the Medicare population, and they've also created a big industry with Medicare. So there's a lot of hospitals, there's a lot of doctors that are accessories to the crime in a sense, and they might say they want it to go away, but do they really want it to go away? Because they're really still accessories to the crime, and that's how them and their whole clinic makes a big living.
Right. There's a lot of money in there. So it
Absolutely.
sounds like empowerment, education, and the forces of a free market can go a long way towards the growth of what you're doing here and the growth of what we're trying to do, and really trying to make a positive change on this industry.
Yeah, ultimately, I think in almost everything, including healthcare, the free market is what solves problems. And you let consumers vote with their pocketbooks and vote with their feet, and the free market will largely fix it, but you have to let it work.
Absolutely. Shawn, thanks for taking the time to chat with us today.
All right. You're welcome, Chris. Thank you so much.
Wish you the best of luck and look forward to following your success.
All right.
That's it for this episode of Healthcare Americana. Thanks for listening. Hi again, everyone. This is Chris. At Healthcare Americana, we're always on the lookout for great stories to tell in the healthcare industry. And we'd like to hear yours. Check out healthcareamericana.com and send us your ideas for episodes or if you'd like to be a guest. Thanks again for listening. Hope you enjoy it.